heard a lot from me today. I am Victoria Chan, Dr. Victoria Chan. I'm a respirologist. I've been at Mackenzie Health for about 30 years. 30 years. And in my journey, I've filled roles in administration such as the Chief of Medicine, Director of Medicine, Director of Emerge, Patient Flow, and the Physician Lead in the EMR, and then Clinical Utilization and Analytics for the 5 years. And currently, I'm the Deputy CMIO. I'm the link to analytics with the EMR. And beside me is a colleague of mine, still a colleague, Felix Zhang. He has had a life in analytics before with ISIS, and he was our Chief Technical Officer, and currently he's the Vice President and the CIO, the Chief Information Officer at Oak Valley Health, which is AKA Markham Stouffville. Yeah. So our talk is a very different one from what you've heard. We are going to be talking about falls prevention, and we're going to talk to you about technology, how the technology was implemented, how we got the clinical teams involved, and how we improved something for the patients. So I just want to read something from one of our PFAC, our Patient Family Advisory Councils, because we are talking about how we should reframe our new strategy. So things like, they were saying, heal me, don't hurt me, listen to me, be nice to me, get me there faster. I just wrote a few more. Save money, but not at my expense. So let's on to our talk. Felix, do you want to start? The clicker is, where's the clicker? It's on the table there.
Oh, yeah.
Sorry. So by the end of our talk, we should be able to achieve the following: how to navigate vendor relationships, accountabilities in a smart hospital towards an organization goal, solve an age-old problem of falls prevention using advanced unified communication ecosystem and data, analyze the difference between the new technology at our smart hospital and compare to conventional falls prevention methods at our legacy hospital, and demonstrate sustained improvement in falls prevention using technology, the EMR, and practice. So one of the things that we're really proud of in our project is that the improvement is sustained, and that can be done by hardwiring the workflows into the environment. So I'm gonna hand it over. You want me to do that? Okay. So the electronic health record sort of is our common thing between our two sites. One site we call our smart hospital has a RTLS system, a real-time location system, smart beds, patient engagement platform, which is sort of an iPad at the bedside, and mobile alerts and communication where the nurses are holding a phone, a mobile device, and they move around with it rather than listening to nurse call, et cetera. So at the other site, we do not have RTLS. We have Wi-Fi, but not the location services. The smart beds are kind of dumb or traditional. We do have the patient engagement platform, and then the mobile alert and communication was yet to come at the beginning of this story. So the challenge: why should we prevent falls on inpatients, or outpatients for that matter? So for the non-clinicians in the room, a fall is deadly. If a patient falls, especially an elderly one, the chances that they're gonna die in 1 year is up to 80%. And also, it's life-changing. Once you fall, you break your hip, you lose your mobility, you may not be able to live on your own, you may not be able to get home, you may actually go from home, breaking your hip, getting it fixed in hospital, and then going out to long-term care. It increased costs, medical legal risks as well to the organization, and also it increases our length of stay. It says, hold on. it increases our length of stay. So according to the CIHI website, a fall increases our length of stay by up to 15 days. So it's a huge cost to the organization. It's to everyone's benefit, especially to the patient, for us to prevent falls as much as we can. So I don't know. I've run out of jokes. So you're going to have to get us back. You're going to have to get us back to our slides. Okay. So the back one slide here. So these were our targets. Our baseline fall rate was 2 falls per 1,000 patient days, and we wanted to decrease it to that level. We were above that. And then year 2, we wanted to decrease by 25% to 1.5 per 1,000 patient days, and then 1.0 per 1,000 patient days. And then year 4, we were trying to push it even further than that. Just for reference sake, most hospitals hover between, if you're really good, at 1 fall per 1,000 patient days, and up to like 2.5, 3, which is considered a bit high. Now this is falls resulting in harm, not just falls slipping to the ground. Okay, so Felix is going to tell us about how we got there with the technology.
Yeah, thank you. So as the operational, clinical operations targets are set, and it falls under the IT's responsibility to basically work with our vendors and the clinical teams to design and implement those solutions. And also, we wanted to embed those technology solutions into the clinical workflows to drive the outcomes. So while there are many case studies about aligning our strategic goals with between IT and the clinical teams, today I'd like to share my experience with how to work with our vendors and engage our vendors to drive the outcomes and why it matters. So as we all know, today's digital environment is increasingly complex. So we have so many systems working in the environment. We not only expect them to deliver their original purpose as they build as a standalone product, we also wanted them to be able to integrate it with other systems, exchange their data with other systems to drive a better efficiency and drive innovation and also deliver better outcomes. So that obviously creates a challenge not only to manage the diverse vendor capabilities, also there are lots of challenges with the interoperability among them. So I view vendors as our extension of our own team, and we take the responsibility, I mean the hospital, we take the responsibility to work with them and navigate through those challenges and align their capabilities with our goals. So with that, and there are some key strategies to how to manage or navigate through this multi-vendor integrative environment. So first of all, we need to establish a very clear problem statement and also the use cases. For example, in this falls prevention scenario, one critical issue was that sometimes we all know that our beds, they are smart beds, but sometimes those beds safety protocols may not be activated. So for those patients with falls risk. And as a result, the bed may not be able to send alerts to nurses and while the patient attempts to leave the bed, and would cause harm. So what we wanted to do was to address this, wanted to basically remind our nurses if those safety protocols were not activated, and so they can go back and activate, ensure the bed will be able to send alerts. Another challenge was the bed exit alerts. If you look at the previous slide, there were different hospitals. So smart bed is able to send through the wireless network, but the traditional or beds, they rely on the nurse call system. So as you may know that there is I think the 37-pin connector. They need to connect it to the head wall in order to transmit that alerts over the nurse call system, and if that connection was not established or no one's at the nursing station to monitor and respond to those alerts, and the patient may just cause the harm So what we wanted to do was to basically send those alerts, bypass the nurse call system, and be able to send it through over the Wi-Fi network onto the nurse's handheld device. So those are kind of use cases that we developed it through our project, and they wanted our vendors to deliver. And so once the use case is being defined, then we basically start to define the roles and responsibility with each of the vendors and what they need to deliver. In order to facilitate that work, we created something called integration matrix. So basically, it's a spreadsheet to identify all the vendors and what the data they're going to be sending, and all what are the data points they'll be receiving from other vendors. And literally, we identify all the data exchange points and walk them through the entire spreadsheet with everyone at the table. So it's not only to ensure they all understand their own responsibilities, but also it's education point. It helps them to understand the big picture, what do we want to accomplish as a whole, and what do we want creating an ecosystem within our environment. So basically, also lastly, it's very important to continue to monitor their progress and the performance throughout the implementation until the solution's been delivered and also passes our end users user acceptance testing and put them into the real clinical environment. So we all know if we don't manage those vendors effectively, and the project will be facing fairly significant risks. And strong vendor management delivers substantial benefits. I'm not going to read through, but it is important to give our vendors as much attention and care as we work with our internal teams. In terms of the vendor relations, as mentioned, I view them as an extension of our own team. And while we want to hold them accountable to the deliverables, but we also need to maintain a positive and a strong relationship with them. So it will go a long way to ensure the success of our project. So there are some of the things we've done in the past. For example, establish a strong governance and centralize the vendor oversight through cross-functional input from other teams. For example, again, the bed contract may be managed by your equipment team, but there's a small portion, just the data exchange and the integration piece. I think from IT perspective, we want to centrally manage them, but with your equipment team at the table, hold the vendor accountable for their deliverables. And also, very importantly, to build a trust relationship and through clarity and transparent communications. So one of the biggest risks for the vendors is the ambiguity in the project scope and the deliverables. And too often, whether it's intentionally or unintentionally, the contract language can be vague and open to interpretation. So I don't know how many of you have been involved in like a redevelopment project, and the PSOS was intentionally written with a lot of space for interpretation. But that creates uncertainty for the vendors. They don't know what exactly they need to deliver, and so as the owner or the project sponsor, it's our responsibility to provide those clarity to our vendors so they can deliver with confidence, and they know if they do this, they will be receiving a acceptance testing or whatever certificate they need to receive in order to close the project. So with sharing the problem statement, clarifying your intention, what you want to accomplish, and also core design those use cases will help you and also help the vendor to be able to foster a more collaborative and a stronger relationship with them. And that brings us to another very important aspect to be able to influence the vendors to align their goals with yours. So one of the important things, so for example, all the vendors are like for profit. There's nothing wrong with that. But as we wanted to be innovative and want the vendors to deliver something they may not have been done before, it requires a lot of critical resources or attention from the executive level in order to support those kind of work. So in fact, as our project, the Mackenzie Health's projects be able to come live, and many of the vendors being very successful by demonstrating their innovation could work in a real hospital environment. So in conclusion, the strong vendor relationship will be able to drive innovation, resilience, and ultimately better patient outcome, which matters most to the hospital.
So the technology, Felix used to be our CTO, but I'm going to describe the technology. So we have the EHR with the patient in the middle, and what happens is we integrated the EHR with the digital room signage. So at our new hospital, we actually have a tablet outside every room, and if we score the patient as high risk, it says high risk of falls, and everybody can see that. The patient also has a bedside tablet so that we can determine, based on the charting, who's going to get the falls education video. So that kind of mimics what we had in the past. We had an education booklet about falls, and then we used to put a paper sign up saying this patient has high risk of falls, and we used to put a purple armband onto the patient. What's new is at our new hospital, we ordered smart beds, which actually has a RTLS location device inside it. So the bed knows who is in it and who is high risk, the bed knows about it. So there's a configuration that we programmed where it's 2 rails up, 2 rails down is the safest way to house a patient who is high risk, because when you put all 4 rails up, when they climb over it, they're going to fall and break their hip or hit their head. At the bottom there, we have mobile alerts and communications. So the nurses is holding a device, and there's a platform on the device which sort of unifies everything from the EMR to the bed. The bed, when the patient's trying to get out of it, will send an alert, which actually go through the system and onto the nurse wherever she's walking. So we're not listening to the beep, beep, beep from the nurse call because the patient who's falling isn't going to call and say, I'm falling, they just fall. So the bed knows when someone's movement is mimicking trying to get out of bed and they're not supposed to, and then it'll send an alert to the nurses. And then the nurses are carrying with their badges an RTLS badge. So we actually have location data on how quickly the nurse comes into the room, and the room knows when a nurse has come into the patient's bedside. So this is a schematic of the different kind of beds that we had. The second one from the left is our traditional bed, and the smart ones are in the middle there and also near the end. So smart beds can integrate with the EMR, and the traditional beds cannot. So what is the difference between the 2 beds? The smart beds have 100% auto alarm and rearm, whereas the traditional beds, 42% of them were smart beds, but 58% of them you had to manually rearm. So RTLS at one location, not at the other, bed integration with our EMR, but not the other side. Digital signage at our smart hospital, the bed configuration. So the railing, 2 rails up, 2 rails down, can only be warning with the smart beds at the smart hospital, but on the other side, the beds could be any configuration. So the bed itself in our smart hospital knows what the falls risk score when their high risk is, and the mobile communication was at the smart hospital. And because of our data, we actually chose to implement very sort of cost-effectively one of the leveraged actions onto the other hospital to equalize it. So here's our data. I put in some of our leveraged actions. We had a safety culture, unit quality boards, the falls dashboard on the wards. People could talk about when the patients were falling. This is falls rate per 1,000 patient days. And then in June of 2021, we opened our smart hospital. And this is our combined thing. Our falls rate started to come down, and we had the high reliability organization in January of 2022. So the average falls rate is in the dotted red line, and the target was our green line. We were trying to get down to 1. So the mobile alert and communication platform, we decided that that's probably the best thing that we could do at the older hospital, because RTLS was not an option. It would have costed too much money to put in that infrastructure into the rooms. And also, we couldn't afford to buy so many smart beds to upgrade all the beds at our legacy hospital. So the main thing you've heard over and over again, when you put a project into place, monitoring the adherence and then the patient outcomes. So we had an incident reporting system, which is outside our EMR, and we wanted to reduce that falls rate. And so this is, I'm going to try to explain here. So the patient gets admitted. The EHR triggers the nurse to say, you must do the falls risk assessment. We monitored that compliance, and then from that, Morse score would fire off different actions. So if the score was greater than or equal to 25, it triggered for the patient to watch the bedside video. From our data, we noticed that not many people watched the video, even though it was triggered. So if the score was greater than 45, the digital signage would actually show up on at our smart hospital saying this is a high risk for a fall. And the bed alarm reminder would go to the mobile for the nurse to turn on the bed alarm. And then if the bed alarm wasn't turned on, it kept firing the message to turn it on. So at our legacy hospital, if the Morse score is greater than 35, later on when we put that technology in for them to have their handheld, they were also told to put on the bed alarm. But if they didn't put on the bed alarm, the bed didn't know that the alarm was on or off. So the goal was to prevent the falls by going into that circle. Patient gets out of bed, nurse comes and attends to the patient, resets the alarm, patient tries to get out of bed, and so forth. So this was one of our unit quality boards. It's a 55-inch TV screen that we put up at the smart hospital. Different data was actually flowing in. So what we would do is have huddles in front of this board, and everyone would talk about how many actual raw falls were charted last week. Not all of them would be going into the incident reporting system. Sometimes it was just a fall where the patient slipped to the ground, but we still wanted to prevent those. So those were the falls with no harm. And in our legacy hospital, there wasn't any room. We still had the cork board on the left, and we turned the TV on its side. So this was monitoring the compliance of the charting. We got everybody up to at least 80, 90%, and then the EMR was smart enough to know that it wasn't charted and reminded people to do it. So this is fresh off the press from a couple weeks ago. So the 90th percentile responses at each hospital, the median at our smart hospital was 6 seconds. Most of the nurses, most of the alerts were attended to within 11 seconds at the smart hospital. In the legacy hospital, there was a huge variation, and the median was actually 23 seconds. The average was hugely different. At the smart hospital, it was 20 seconds, and the average was 40 seconds higher at the legacy hospital. There's lots of reasons why the difference is there. The layout is completely different. The technology is different. More experienced nurses at the legacy site versus the new site. So we're still trying to digest this data to figure out what it means. So as I said, nearly 90,000 bed exit alerts were responded to in under 11 seconds at the smart hospital. Okay, so when you're incident reporting, you can make yourself look good by not reporting. So we actually looked at the number of falls reporting over time to make sure that we were entering all the ones that we should be entering. So this is sort of the total falls charting in our incident reporting system. there's a few things there. And then I decided to look at it again before this talk to see if it was per 1,000 patient days, and we were not increasing. It was steadily increasing. So the average length of stay between the two sites was higher at one site than the other, but with the spread and everything, it was not significant. The falls risk score was about the same. The average age on admission was relatively the same. The gender was a little bit different, and we weren't really sure what that meant. So the falls rate with harm across the two sites, the legacy hospital is in orange, and our Smart Hospital is in purple. And as you can see, the whole falls rate was coming down. You can see it better in this rolling average graph. The Smart Hospital here is in orange, and the legacy hospital is in purple. There's a huge delta between the two hospitals. So right now, they're approaching each other as we put the mobile communication platform and the bedside tablet at the old site. So I was talking about the length of stay being affected by the falls, and out of the Gemini study, out of 35 hospitals, we had the lowest length of stay for that time period that we were looking at this. So we were just doing a calculation for the HIMSS validation. They wanted to know what was the percentage, what was the dollar saved from decreasing the falls rate. So basically the length of stay for a fall is 14.3 days versus average of 7.5 days without a fall. And this is from the CIHI data 2016-2017 from their website, the cost of falls in Canada. So essentially, we saved, this was the savings from the reduction in falls, but more importantly, the reduction in falls actually improves that patient's outcomes. Like, forget about the money. We harmed people way less by having them not fall when they were in our hospital. So the lessons learned, you can use the EHR to provide the foundation for a standardized evidence-based approach to falls prevention, and you can use the EHR to hardwire the workflows rather than reminding people and sending out education or having pamphlets produced. Culture change is really difficult, but if you hardwire the workflows into your technology, it can be a powerful tool. Alerts designed to fire at the right time, at the right place, support faster clinical responses, and alert fatigue is a big deal. We're still dealing with that. Smart technologies serve as enablers, not drivers, by enhancing the people processes. And finally, the dashboards and data sharing inform progress and effectiveness of the leveraged actions that were planned. So with that, we can take some questions. Yes, there in the back.
Great talk. My mom recently had a fall, so I'm following this pretty close. You mentioned the sensors on the beds had like you want to be able to avoid the patient falling, not respond once they fall. So I was wondering, how do you measure, what's the threshold where it's going to alert a nurse, oh, this patient's going to try and get out of bed?
Well, that's the technology team. We are actually playing with the sensitivity of the beds to figure out when we would alert, because if you just shifted, you didn't want all the shifts and the turning around in the bed to fire it off an alert. It would be enough of a movement that they're actually climbing out of the bed and the weight is actually lifting off the bed, which would fire off the notification to the nurse. So it's really funny because when we first moved into the new hospital, we were all complaining that, oh my goodness, did you guys notice we were taking 10,000 steps a day? The old hospital, you could just circle around those 4 bedrooms. And so it makes no sense to me that it's a much larger footprint and yet the response time is a lot quicker. But one of the reasons could be that when the nurse comes into the room, the RTLS senses in the room, it shuts the bed alarm off. They have to rearm it. So it could just be that the difference is the nurses were kind of tending to the patient and then shutting off the bed alarm at the legacy hospital. So you see, you can't just use the data and then publicize it and say, oh, this is so great. You have to tie it back to what the clinical workflow is. Any other questions?
Have you implemented any of the updates from the, I'm right here.
Oh, hi.
Have you implemented any of the changes from the smart hospital into the legacy hospital, and what benefits have you seen?
Have we implemented the technology into the legacy
Yeah.
hospital? Well, our first hospital was built in 1963 with different parts added after that. So if you dug into the walls to put in the RTLS system, we would disturb the asbestos. So we were told by our redevelopment team that we can't do such a thing. And putting in conduits is actually very messy and very costly. So I think it's pretty good that we did the mobile communication system without disturbing the infrastructure, because that would cost a lot more money. I don't know, Felix, did you have any comment
Yeah, I just
about
wanted
that?
to add, because now the newer beds, they are able to communicate wirelessly, so you don't have to put those very
Right.
expensive infrastructure behind the wall. So, but obviously, it takes time to phase out the old beds and put the new beds in, so that's why I think Mackenzie Health has that strategy to implement those solutions unit by unit over time.
So in our hospital, we actually use the data that came out from the project to decide what technology we were going to use in the old hospital.
Yeah.
And some of it is actually translatable, because if you just have Wi-Fi now with a smart bed and the mobile device, you don't need all that hardwire stuff into the actual hospital itself. Okay, great. Thank you.
Thank you, everyone.